cuneiform to the base of the second metatarsal. So this injury strictly refers to an injury where one or more of the metatarsals are displaced from the tarsus. The term is more commonly used to describe an injury to the midfoot centered on the second tarsal metatarsal joint. Incidence is pretty low, is 0.2% of all fractures, and the male are more affected than female. And very important, it's a really sports-related cuniform to the base of the second riding, running are the most cuniform to the base of the second sports that so this injury strictly refers to an injury where one or more of the metatarsals are displaced direct trauma from the tarsus. So the direct term is more commonly used to describe an injury, severe soft tissue injuries. They can be devastating the midfoot centered on the second tarsal metatarsal joint syndrome. Incidence is pretty low, is 0.2% of all fractures, and the male are more affected than female. And very important, it's a really here you can find a short video. There is a NBA was a Linksfrank injury is more in the player, and you can find here we can start. I hope. I'm sorry. You can find here, you can follow the player, you can find here the moment of the crash on the foot, and this is the result. So the commonly described mechanism of injury are similar in both pediatric and adult reports of Linksfrank injuries, with most occurring from either a direct plantar force or indirect rotational force with the foot in plantar flexion. So diagnosis less severe Linksfrank injuries can be a challenge and requires the clinician to have a high index of suspicion. So it is very important the clinical signs are often more subtle of the history and mechanism of injuries is less dramatic. There is often pain, swelling, and tenderness of over the area of the Linksfrank joint, but no deformity or loss of the medial arch. So the presence of plantar ecchymosis is highly suggestive of Linksfrank injury and should be therefore prompt further investigation. So you have first to have the suspect, and then you can dip the diagnosis. Relatively little evidence existed to guide the approach to the diagnosis or the management of Linksfrank injuries in pediatric population. A limited number of cases exist in the pediatric orthopedic literature, the largest including only 18 patients. So these injuries in children are not only rare, but they are also similar to adult Linksfrank injuries in that they are commonly misdiagnosed or overlooked. So it is very important, of course, the plan X-ray first, then scintigraphy, and in some cases, a CT scan and MRI, which have over 90% of sensitivity of this kind of a lesion. So Linksfrank injuries are initially investigated by unilateral non-weighted bearing plane radiography, which comprise an anterior, posterior, internal, oblique, and lateral view. There are often enough to demonstrate more obvious Linksfrank fractures dislocation, but miss a significant number of more subtle injuries. Has been shown that in up over 50% of the patient, this radiograph, non-weight bearing radiograph, were normal and missed the diastasis between the first and the second metatarsal. Recently, this paper has been shown that craniocaudal angulation in AP radiograph view improves the visualization of the Linksfrank joint in the majority of patients. And furthermore, in equivocal case, weight-bearing radiographs of both feet can be done to identify subtle differences. The distance between the bases of the first and the second metatarsal, which should not exceed 2 millimeters. When this radiological sign is present, it means it's called flex sign. A small chip of bone found in the space between the first and the second metatarsal bases indicates avulsion of the Linksfrank ligaments. Regarding the classification of Linksfrank injuries was originally described by Kino and Kuss in 1909 and based on the 3 columns concept. Furthermore, later in 1982, this classification was modified by R. Castle into A, B, and C categories, and then a further modified classification system accounting for the complexity of the injuries was proposed by Meyerson and others in 1986. So you can find here how is complex this kind of classification, which differentiate between total incongruity, partial incongruity, or divergent incongruity. So you can find here much better in this slide how complex is the possibility to have this kind of injuries, how difficult it is to try to recall an injury so rare like this. Anyway, stable, undisplaced injuries can be managed non-surgically with a non-weight-bearing cast for 6 weeks, and if ligamentous disruption is present, a longer period of immobilization can be required, even 3 or 4 months. Patients with displaced or unstable injuries require surgical treatment with anatomical reduction, and a delay in surgery is recommended until the swelling has subsided, indicating the skin wrinkling. So adult Lisfranc injuries frequently require surgery to obtain anatomic stable reduction, whereas pediatric injuries may be treated successfully without operative treatment. So this is a paper 4 years ago, 2017, which report the experience of this author, and there is a 56 fracture, 59 fracture dislocation, and 17 sprains. And group of 70% of patients with open physes were treated non-operatively, whereas over 60% of patients with closed physes were treated surgically. So there are several techniques to fix the Lisfranc injuries. In general, they are reduced from proximal to distal and from medial to lateral, after which they are temporarily held with K-wires. In the adult population, the incidence of post-traumatic arthritis has been documented in 1/4 of patients, so it's pretty high. And regarding the Chopard complex injuries are really uncommon. Recent literature states the rate of misdiagnosis to be between 20 and 41%. So Chopard lesion may be confused with ankle sprain, and it's very challenging for diagnosis. And the Chopard complex consists of 2 separate but interrelated joints. These include the talonavicular joint of the medial side and the calcaneocuboid joint laterally, which separate the hindfoot from the midfoot. And strong ligaments bind the joints together, providing stability with global foot motion. Chopard complex injuries have been described as rare, but many are probably missed or misdiagnosed and therefore underreported. And the literature states that 20 to 14% of injuries are initially missed. So the most important function of this joint is during the strength phase when the foot supports the body weight. And the Chopard complex has a high degree of mobility, which allows to the hindfoot to pivot while the forefoot remains stationary on the ground. This joint complex, together with the subtalar joint, function as a unit to invert and divert the foot. So this kind of injury is really rare and recognize a low energy twisting force applied to the plantar flexed foot. And the classification, even in this case, there are 2 main classifications, is Main and Jowett and Sweep classification. The Main and Jowett classification is based on the injury mechanism. On the other side, the Sweep classification is more complex. We can recognize. You can hear some in the scheme, some of the line with a color code in order to have more easy for you to recognize the different pattern. Is transligamentous, transtalar, transcalcaneal, transnavicular, transcuboidal, and combined. Any combination of 2 to 5 of this kind of injuries. It's important to mention that combined injuries make up more than 40% of Chopard injuries. For the imaging, nothing new. Of course, we need to X-ray, and then a CT scan and MRI can improve the quality of images and have a better visualization of this kind of injuries. Conservative treatment of this property injuries is possible in those cases without dislocation and or displacement of the fracture fragments. This could include extra-articular fractures, impacted articular fracture, in particular involving the lateral column, as it's functionally more tolerant as regard long-term outcome. Closed rigid below knee cast applied for 6 to 8 weeks. And surgical treatment, the medial columns is the loading component and less forgiving to any displacement, and thus anatomic reduction with rigid fixation is indicated. There is a little casuistic or series of cases concerning the following isolated Chopard injuries as opposed to a combined Chopard and Lisfranc injuries. So the post-traumatic flat foot is rarely discussed or documented in the literature, but is a real risk following Chopard lesion, especially if the injury is misdiagnosed and not appropriately treated. So in conclusion, this is a Lisfranc and Chopard lesion are rare entities. The injury is sport-related in most of cases, and often they are underestimated and misdiagnosed. So we have to first to suspect, because the history of the trauma is very important, then to suspect this kind of injury. Conservative treatment in children is appropriate in most of the cases, but don't hesitate to treat surgically the severe injuries. And patient not properly managed can have an high incidence of long-term disability. Thank you very much for your attention.
Do you have to tell us what is your experience in close manipulation in such injuries if diagnosed properly?
So you can first, of course, under general anesthesia to try to reduce the fracture, and then to test the stability or the instability of the fracture. So in the most of cases, especially for the child, for the young child, for under 14 years of age, you can fix just only with K-wires without to have a big surgery. But the first is one of the emergencies, so it's better to go first in the OR and try to reduce and fix this kind of lesion, especially when it is a dislocation. The most challenge in other cases is not when the trauma is really evident, and there is more subtle, because it's very difficult sometimes to recognize this kind of fracture, and then you can have to have a screw up and to try to think it's just only a sprain. So you maintain an immobilization just for a couple of weeks, and the patient started to complain for the pain because there is not be able to walk because you didn't recognize at the beginning this kind of lesion. So you have to balance between the two situations. The most important is more evident. You can find you can go to the OR and maybe you can fix the fracture and you are be able to manage it. More subtle and challenge is the diagnosis in more mild lesion of this kind of joint.
So from your last word, I ask you one question. What is your message to the audience when to proceed for more investigation? What are the suspicious clinical signs or in the history of the patient that guide him the patient may have Lisfranc or Chopard injuries?
So you have, I underline this concept because it's very important to collect the history of the trauma. Yeah. Because very often, at least in my country, there is no more contact sports, but there is football, the soccer, and then the soccer is usually when the the other player push down with the foot the foot of the opponent player, and like a little bit have you seen during the clip, and you have to suspect this kind of injury just only on the history of the trauma. The second point is to try to investigate clinically, and if you find just the chemosis on the plantar surface of the foot, you can suspect this kind of injury. And third, for the plain X-ray, you try to obtain more as much as possible lateral view, oblique view, in order just to see this kind of lesion. If you are lucky, you can find or recognize the flex sign, but you have to know there is a flex sign. Otherwise, you can misunderstand what are you saying. And the second, if you don't be able on the plain X-ray to recognize the fracture, so you can deep the diagnosis with a CT scan or better MRI. MRI, of course, is not an emergency examination, so you can wait for 1 day or 2 days or 3 days just only to obtain a real diagnosis in any way to exclude this kind of lesion.
Also, I think MRI is less radio diagnosis exposure, X-ray exposure for the child. Okay, MRI is better than the CT.
Absolutely. Right?
Yes.
Yeah. No, just only I wanted to underline, as you told, it's better to wait for 2 or 3 days, especially for the mild lesion, just in order to have a correct diagnosis with the correct examination.
But it's better to do an MRI to avoid the X-ray exposure for the child. Last question. Yes.
Right? First, of course, you yes. Take an X-ray when you suspect there's these lesions, and you can dip with an MRI. Yeah.
Yes. Last question for this type of injuries: what is the commonest obstacle do you find after failure of the closed manipulation? If you try to do closed manipulation and then it is not reduced, you will proceed for open. What is the commonest obstacle for this missed correction or inability to closely treat this injury?
But you have to open, but in the most of the cases, if you adjust, even, I mean, there is a real disruption of the joint where there is a massive disruption. So it's really rare to front or to manage just the least frank ligament or whatever. If you are in front of, like some cases I showed in the X-ray, you had a complete disruption of the metatarsal and cuboid joint. So you can open and you find you are easy to reduce. The difficult way is to maintain the reduction. But sometimes, especially for the kids, you don't have to use so many hardware. The K-wires, usually it's enough to maintain the reduction. But it's really important to have a reduction, because the long-term disability is pretty high in this patient if you don't try to reduce in the proper way the lesion.
Yes. Thank you very much, Professor Antonio, for your time. And we know that you have a commitment and you are busy. You can leave our meeting, and thank you so much for you attending at that time.
Thank you for hosting me. Thank you.
Thank you so much. Thank you.
Thank you. Bye-bye. Thanks.
Okay, bye.
Bye.
Now we shift to a very nice, interesting topic, which is the flexible intramedullary nailing of long bone fracture in the lower limb. And our guest speaker is one of the famous professor of such technique, is Professor Pierre Journoux from France. And I welcome you, and please go on.
Dear colleagues, it is a real great pleasure to be here this evening for sharing some key points about flexible intramedullary nailing in pediatric traumatology. The flexible nailing is born in Nancy, France. The name in French is ECMES, embrochage centromédulaire élastique stable. Easy in Europe, elastic stable intramedullary nailing, and flexible intramedullary nailing in US. Why should you to know the flexible nailing? Because in children, we observe more than 30 million fractures a year. And if we consider the treatments, flexible nailing means more than 40% of surgical treatments. The rate of conservative treatment is very high, but the other implants, as screw, carrier, or plates, are very low in the surgical treatment in fracture. For the best understanding of flexible nailing, it's very important to know some biomechanical principle and some technical points. What is the concept of the flexible nailing? Imagine a sailing boat under the wind, and you have a balance between the waves, wind, and boat, and it is exactly the same concept between the shaft, medial muscles, and lateral muscles. In case of fracture, we use two both nails face to face with a large bending, and the both bending balances the power of the muscles. In summary, the biomechanical principle are to use always two nails face to face with a maximum bending of 40% at the level of the fracture, and to have 6 points of anchorage, 2 points at the same level of the introduction, 2 points on the tip with a very high pressure for impaction, and 2 points at the level of the femoral shaft fracture. The other question is titanium or steel. If we consider the results before 10 years old, the functional outcomes are equal. In comparison with a teenager, it's better to use steel because the nails in steel are more rigid, less elastic, and sometimes cheaper. To demonstrate the mechanism and the biomechanical principle of the flexible nailing, you need to imagine to put the first nail in the lateral part of the shaft. The bending increase the valgus deformity, and when you put the second nail, you have a compression in the varus deformity to have a big balance between the both nails if we respect the technical points. The second point of the flexible nailing is to avoid the complication, because many papers demonstrate some complication, but if you respect the technical points, it's very easy to decrease the rate of complication. If we consider the literature, the main complications are the skin problems, malunion, and the rate of fracture. In our series, since 1985, we observe a very low rate of complication in comparison with the literature. And the question is how to avoid this complication to have the best treatment and the best results. The first point is the skin problem, because when you impact the nail at the end, some surgeons want to bend the nail to avoid secondary displacement. In reality, it's easier to use the elasticity of the nail, and the nail move along the shaft to avoid the skin irritation. The second point is to use a special devices for cutting properly and to impact with a special device the nail into the shaft. Few millimeters are helpful to remove the nail, but we need to keep only 3, 4, 5 millimeters outside of the bone. The second complication is the malunion, and the main reason is the rate and the ratio between the internal canal of the bone and the diameter of the nail. The best ratio is 40% for each nail. Keep in mind that over 10 or 11 years, you need to use always 4 millimeters of diameter for each nail in case of fracture for the lower limbs, as femur or tibia. For the upper limb is less important because you are not thread bearing, but the ratio of 40% is a real cause of malunion if you don't respect this ratio. You can see here some bad example using inappropriate ratio of the nail for the fracture with a secondary displacement or malunion and meaning a new procedure to have a good outcomes. Therefore, to prove this ratio, we have made a survey and we observe that below 45% of ratio, we observe many times the highest rate of complication as malunion or secondary displacement. The ratio over 35% is better to use 40%, but more than 45%, the optimal ratio leads to a good functional outcomes. The third problem is the recurrent fracture. We can observe two situations. The first one is the recurrent fracture when the nails are yet inside the bone. The solution is very simple. It's very easy to bend, reverse the nail to restore the axis of the bone. The second question is when do we remove the nail to avoid the recurrent fracture? Usually, for each bones, we have some recommendation for removal of the nails. Concerning the forearms, we have a very, very thick cortex, and usually we need to keep the nail over 6 months. If you remove the nail before 6 months, you increase the risk of refracture. And if you have a refracture after too early removal, it's not very easy to put another nail because you have some bone inside, and usually we need to perform open approach for putting the nail. In summaries, in our series, we have compared the two series of forearm fracture with removal before and after 6 months. The rate is very significant, and we have more than 6% of recurrent fracture when we remove the nail before 6 months. And our recommendation is to keep the nail over 6 and sometimes 7 or 8 in case of open fracture, because the bone healing is very, very with a low speed. The other complications are from the anatomy, because the approach are very small incisions, and you need to keep some nerves or some tendon to avoid paresthesia and some neurological problems. For the forearms, we have some problem with pollicis longus tendon, especially in case of posteromedial approach. We perform this posteromedial approach in case of third distal fracture, because in this case, we perform the bend in the maximum to restore the curvature of the radius. The key point 3 is to choose the kind of flexible nailing according to the bone and according to the kind of the fracture. In the femoral shaft fracture, the limit is usually 11 or 12 years old and 50 or 60 kilograms. Until this kind of patients, from 10 years old, the size of the nail must be always 4 millimeters. Below 4 millimeters, the ratio will be not good, and the risk of malunion or secondary displacement is very high. The nail bending must be more than 40%, and it is very important to put the nail respecting the 6 points of anchorage. Sometimes you can put the nail through the cortex, as in this example, to improve the stability of the nail. For the distal third femoral fracture, the antegrade flexible nailing is very helpful, because you can use unipolar approach just below the greater trochanter using 2 holes, and the maximum bending is always at the maximum at the level of the fracture. And sometimes you can put the nail through the physis for increasing the stability. If you put the nail only 1 time through the physis, you cannot observe any gross disturbances. The problem of the leg fracture in children is a fibula, because in more than 50% of the leg fractures, the fibula is intact. In this case, when the fibula is intact, the problem is a varus deformity if you use bipolar and the classical flexible nailing. And the most important in case of intact fibula is to use 2 bending in the same curvature, in the same direction, in valgus deformity, to avoid varus deformity. You can use bipolar approach if you want, but the tip, the end tip of the nail must be in the valgus way for avoiding a varus deformity. For the forearm fracture, it's a very special fracture because the canal is usually very, very narrow, and it's very difficult to put the nail. And don't hesitate to use an open approach for performing flexible nailing. In our series, we have about 10 to 15% of open approach. We need to use 1 nail for each bone, or never only 1 nail, because if you use only 1 nail, we haven't any elasticity and any balance between the both bones. The hammer is useful to put the nail, especially in case of narrowing a canal. And after flexible nailing, don't hesitate to test the pronation and supination to avoid malrotation after bone healing. The last point is to remove the nail over 6 to 8 months to avoid the refracture. Just a little game in this picture, because it's like a 7 errors game. If you consider this flexible nailing, but it's not really a flexible nailing because you have the very thin nails. The approach is not perfect to hide here, through the olecranon here, bad reduction, bad balance, and of course, malunion and secondary displacement. This flexible nailing do not respect the technical points and do not respect biomechanical principle. Concerning the radial neck fracture, a very precise point must be known. You need to use a sharp nail because the bone in the radial head is very strong, like a cancellous bone. And if you use a cut nail, you cannot put the nail into the bone. You will push the radial head without any reduction and any stabilization. For that, you put the sharp nail with a hammer to impact the tip of the nail in the radial head. Then you rotate progressively the nail for performing the radial head reduction. Sometimes it is better to improve the reduction by a mild pronation in the same time as nail rotation. And at the end, if the reduction is not absolutely perfect, you can remove the nail for a few centimeters, rotate again, impact again, and re-rotate again to perform a nice reduction. To conclude, we are writing 2 books, one in French and one in English. And if you want to improve your knowledge in flexible nailing, don't hesitate to read this book and to see the picture. I thank you for your attention, and I'm available for discussion and some questions.
Professor Pierre, we postpone discussion after our next speaker, Professor Virgal Monsell from UK. He will speak about open fracture of the tibia, because I have many questions for you, Pierre. 2 questions for this issue, especially the head radius. Yes, Professor Virgal.
Okay, thanks very much for the opportunity to speak to you this evening. The first thing to say is I'd just like to point out that my experience is entirely from the context of the United Kingdom. And I appreciate that the majority of the audience to this talk is from Egypt. There are many similarities, but there are also important differences. And if you look at the land mass, about 1 million square kilometers, about 83 million people. In the UK, about 250,000 kilometers squared and about 62 million people. So what? Well, it means that the population densities in both are quite different, with about 2.5 times the population density in the UK. Also, if you look at the age distribution of people in each country, about 2 times more kids aged 0 to 14. And so one other statistic is it looks as if you live in Egypt, you're substantially more likely to be involved in a road traffic accident. So I'm not going to do any science in this talk, but what it does point out to me is that you've got more room, you've got more kids, and you've got more car accidents. So you probably will see substantially more open trauma than I will. And so the first thing I'd like to say is I'm embarrassed talking to an already expert audience, but I will do my best nevertheless. I'd like to give you our perspective from the United Kingdom. And in the UK, before 2014, we really had a lack of consensus of management. It was where you ended up dictated what you did. It was, you know, some broad rules, but no consensus. We really didn't have any robust outcomes, probably because the volume of cases were small and distributed through a number of centres. And there were resource implications which probably impeded change in our system. And that was both resource concerning orthopaedic surgery and resource concerning plastic surgery. Now, in our practice, in 2014, we developed a national trauma network. And in 2014, children went on stream and our hospital became a level 1 major trauma centre. And at the time, it was very clear that we had very little idea about how to manage what was going to be an increase in open tibial open trauma in general and tibial trauma in particular. And so at that time, myself and one of my colleagues and friends in plastic surgery sat down and said, this is what we're going to do. Now, the purpose of this talk is to tell you what we did, not what you should do. I hope there's some things that you can take from it, but this is what we did, and this is what we achieved by doing it. We've got a catchment of about 5 million people. And so we developed a management algorithm which was based on the British Orthopaedic Association guidelines for open fractures in general. And we took a view that there was absolutely no difference between the management of the adult fracture and the pediatric fracture, and that we were going to not only aspire to meet these guidelines, but also to actually be more aggressive about them. And we felt that with the literature suggesting a 10% deep infection rate in some series, that we had to do better than that. We also had an opportunity to look carefully at our outcomes, because for once, all patients were concentrated and we would be able to follow them to union and beyond, and we'd be able to get an idea as to whether what we perceived was going to be an aggressive approach, which would be easy to criticize, had any benefit for the patients. And that's what we saw in the first 5 years of being an MTC. And I know that in many parts of the world, that's probably a weekend's work. But where we are, that's what we see in our practice in patients under 16 years. And the mean age is 9.9. There is quite a broad spread, and the majority are high energy motor vehicle accidents, mainly males and mainly driving motor vehicles, cars, motorcycles, or pedestrians hit by them. The distribution was predictable. The majority are either mid-shaft or distal, with very few being proximal. And in terms of the distribution of soft tissue injury, which I think is the crucial point, there were 8 grade 1s, and the majority of the others were gustalo 3s, of which the overwhelming majority were 3Bs. So this is really a talk of our experience in managing the 3B tibia in the under 16-year-old patient. This is a typical example. I picked this is a 14-year-old he's been involved in a pedestrian versus car accident. He's skeletally mature, but he still comes under our care. And this is the interface between pediatric and adult trauma, which I think we don't do in the UK, we don't do particularly well. But this is our responsibility. They will not see an adult surgeon, but we will play by the same rules. And so what we want to do is we want to have an efficient, almost reflex system that goes into action as soon as the patient arrives. And this is what we teach our residents. We agree as our consultants that this is what happens. And if this doesn't happen, there has to be an explanation as to why it didn't happen. And so first of all, into the emergency department, initial resuscitation and management is done by our juniors, by our orthopedic registrar and our plastic registrar, both attending in the emergency room. No phone calls, no I'm at home, call me when you need me. They are attending from the minute that there's an open fracture in the building, they are present. Then into the initial inspection of the operating theatre, we have a plastics consultant and an orthopedic consultant. We think, as with the adult practice, that where these cases go wrong starts very early. If the initial decisions are inappropriate, the outcome will be compromised. So we want senior decision makers in the operating room for the first look. And the assessment in theatre has to be a decision maker. What drives me nuts is the notion of someone holding a mobile phone, talking to someone on the other end, giving them instructions. We don't want that. We want people in the operating room. We have a systematic approach which is aggressive. I take care of the bone, whatever's needed, assessment, cleaning, resection, and then I hand over to my plastic surgery consultant colleague who deals with the soft tissue wound excision, not debridement, we call it an excision. Any obviously dead tissue is removed, and we'll have a second look and then proceed. And the wound is extended as necessary. And so just from our group, the median time to first episode was 11 hours. From injury to first look, consultant in theatre was 11 hours. And all patients were within 24 hours, which is within the guidelines that were suggested by the BOA back press document. This is available on the BOA website. It can be easily downloaded. So the initial management of the 3B tibia, 100% orthopedic consultant present over a 5-year period, 94% plastics consultant, but a plastics decision maker, which is usually a fellow who's on the verge of being a consultant 100% of the time. So we managed to achieve that standard. The time to antibiotics was 3 hours. The benefit of having all this now database and prospectively counted is we can look back at our performance. Time to antibiotics from injury, 3 hours median time, and the time to initial stabilization of 11 hours. It doesn't really matter what you use. We used a circular fixator in about a third, a monolateral in about 2/3, and plaster in about 4 cases. Whoever's on call makes a decision, and most of these injuries require some sort of external fixator. If we're looking to do any transport or any sophisticated X-fixer, I'll go straight for a circular fixator because that's a big part of my practice. But I didn't want to put my colleagues off, and so a monolateral fixator is the majority device, and it works in a perfectly straightforward way. So this is the same boy at 5 hours with a monolateral fixator, a wide wound excision, and the majority of our patients get a VAC dressing, and then they're set up for the definitive bone and soft tissue procedure. They go to the high dependency unit as a matter of course. We don't have to find them a bed. This is all absolutely automatic. We want to get them within 48 hours to any specific radiology. And if there's a free flap involved, I know this is a femoral fracture, but we want a CT angiogram so that we can plan for the vascular anatomy of a free flap. And that's done on the day between presentation and definitive surgery. And this is where it gets difficult because there's a resource implication about how do you get operating theatre time. So what we do, we each have a trauma list, and if there is an open fracture, each of us donates a half-day list. So we have an all-day list, which is not argued about. It's equal partnership, plastic surgery, orthopedic surgery, and that has worked consistently for the period we're talking about. And the mean time for the definitive episode, almost 50 hours, and 65% had definitive soft tissue and skeletal surgery within 72 hours of their injury. And the definitive management, again, is whatever the fracture pattern demands. And other people will speak more eloquently about the management of tibial fractures. We used a variety of devices depending on the circumstance. plaster of Paris in a very young child, intermedullary nails in the adolescent group, and a mixture of plates and external fixation, depending on the fracture configuration, soft tissue injury, and preference of the surgeon. And the soft tissue management, the plastic surgeons in our unit are aggressive and expert at soft tissue coverage, and they very routinely use free tissue transfer, scapular, parascapular, ALT, gracilis, or a gastroc swing flap or a local flap to get immediate coverage. And this is this boy, 48 hours after injury, he's got an ALT flap, an intramedullary nail, he is now fixed. Then they go to HTU and they have a flap protocol for 5 days, and they're in hospital for mean time of 7 days. Mean time to union of the whole group is 12 weeks, but I'm just going to direct you to the Gusto 3 fractures, mean time to union, clinical and radiological of 13.75 weeks with no case of of non-union. An Anakin score is a score that my plastic surgery colleagues use to assess not only the transfer, but also the donor site. And we were able to assess 77% of the free flap patients at a median time of 15 months following injury. 100% is perfectly normal function at both recipient and donor site, and our median score was 90%. And it takes into consideration functional issues, cosmetic issues, shoe wear issues, clothing, etc. It's a wide score that takes into all these things into account. Now, complications. I almost laugh about putting this up, but because we use the majority of hexapods or plates or nails, we shouldn't be getting deformity, and we don't want to see deformity. We don't want to have to worry about that. So we aim for anatomical reduction, and that's what we've got in this series. Now, I know this is overcalling it. I know that there's a tolerance which we're not using, but this is what we went for, and this is what I'm reporting to you. Infection, 1 superficial flap infection responded to all antibiotics, 4 pin side infections on the hexapods that we used definitively, but there was no evidence of deep infection. So with this protocol, in a 5-year period, we were able to get anatomical union without infection in every case. I put this as an extreme example. I think it's useful to demonstrate to you, but certainly to remind myself what we can salvage in correct circumstances. And then the tibial fracture is not the particularly difficult issue, but the soft tissue loss here, for me, that would be pretty much a dirty amputation, a through knee with poor soft tissues. The plantar soft tissues were intact and sensate. And so my plastic surgery colleague, who is a phenomenal surgeon, said, no, this is worth every go at salvage. And so I took care of the fracture. I built a fixator, which allowed him to take care of the soft tissue loss. And he created a propeller flap and a split skin graft, which the fracture healed without incident. And at 18 months, it looks like he's in quite considerable valgus, but that medial bump is actually a soft tissue flap, which does throw your eye. But at 18 months, that's what he looks like, and this is how he functions. And so for me, this was a great learning experience, because when I saw that in the crash room, I was pretty depressed about this. There was absolutely no chance that this could be salvaged. But I think with aggressive, structured approach to these injuries, you can extend the indications for limb salvage quite considerably. And so my conclusion, based on a small series in one place, where we have got buy-in from orthopedic surgeons and plastic surgeons, is that with aggressive orthoplastic care, it is possible to manage the most severe open tibial fractures with 100% union, no deep infection, and excellent patient-reported outcomes. And as I stressed to you, this is only telling you what we did. I absolutely understand why this is difficult to translate into other practice elsewhere, but my remit was just to describe to you my experience, which I'm very happy to be able to do. And thank you very much for your attention.
Thank you, Professor Verga, and also we are all very happy for your algorithm. Now we shift to last speaker, Professor Rigi, he will speak about very interesting subject. How can we manage or how to approach patients with post-traumatic gross plate arrest? It's a challenging problem, and please, Professor Rigi, go on.
You see the screen?
Yes.
Okay.
Yes, perfect.
First, مساء الخير, and I would like to thank Professor Gamal Hosni for inviting me. I'm very happy to be back and to present on the gross plate arrest post trauma. Essentially, what I'm going to present is an algorithm. It was, I presented it before, but it's an algorithm how to approach in a systematic way gross plate injury. I don't have anything to declare. Thank you again, Gamal, for inviting me. So gross plate injury, there are several points to be considered before we start even the treatment. Age of the patient at the time of the injury is very important. Obviously, the younger the patient, the more severe the impact will be. The nature and the severity of the trauma, most of us believe that the Salter 4 and 5 are the most serious. However, any type of Salter injury can lead to a gross plate damage. The anatomical location of the gross plate during the accident, the knee joint is the worst one because you need a very high energy to cause fracture the distal femur, and that's the worst, the gross plate arrest that we can have. We're going to talk a bit about the complete, but mostly it will be the partial gross plate injury. If you have a complete injury, well, we know this will lead to a limb length discrepancy. What interests us during this talk, it's the partial injury to the gross plate. And is it resectable or not if you have a bony bar? And do you have a bony bar or it's simply a sick physis? Three key issues guide the treatment of gross plate injury in children. The first one is that if there is a deformity, you have to correct it. The second thing, you have to maintain the correction. And number three, you have to address the LLD. These three cases really address a partial gross plate with a bar that cannot be resected. That will be apparent in the algorithm that you are going to see. High index of suspicion for ball gross plate injury, extremely important. Any gross plate injury has to be followed, and has to be followed at regular and frequent interval, at least for 18 months in our institution. For severe injuries, even more than this. And the key thing is that if you are capable of diagnosing the injury early, then you will have time to intervene and prevent a severe deformity from developing. Now, the first thing is that if there is a bony bar, you followed all the things, but there is a bony bar that appears clinically. The next step that you have to decide, what type of bar is it? Is it a peripheral or is it central bar? Obviously, that takes an MRI to diagnose this, but that's the first step that you have to do. The second thing you want to know if this bar is resectable or not, And we do what we call the mapping of the bar. You do it with usually CT scan, MRI, but you have to know how much of the gross plate is affected. And as a general rule, if it's more than 25 or 30% of the plate that is affected, then it is unresectable. Even though in some reports, especially Hamlet-Peterson, he went to up to 50%. There are several things that you have to take into consideration before deciding excising the bar or not. We all know that trauma is the best etiology to resect a bar. Central bar resection, they do better than the peripheral ones. The physis that is affected definitely plays a role. I already mentioned that the distal femur in general has a very poor prognosis of resection of the bar because it's a very high energy trauma that is required. Distal tibia offers the best prognosis. Extent of the arrest, really what we follow, it's about 20 to 30%. I don't think anyone has reproduced Hamlet-Peterson results of a successful resection after 50%. And the last thing to consider is that you have to have at least 2 years of gross left in order to do resection, otherwise it's not worthwhile. Something also that is overlooked, if the child is very young and he has a bar, even though it's 50 or 60% or even more, it is worthwhile trying to excise it because we don't have an alternative. The alternative will be multiple lengthening. So it's better to give it a try, even if there is a slight chance that it might be successful. So that's what I would like to come is an algorithm that we have developed how to approach partial growth arrest. So the first thing that we have to decide, is it a partial or is it a complete growth arrest? If it's a complete growth arrest, then this becomes a limb length discrepancy, and we are not going to talk about it. The LLD depends obviously at the LLD at skeletal maturity, and you have variable option, do nothing, issue it, or contralateral epiphysiodesis or lengthening. If you have a partial growth arrest, it's either a sick physis without a bony bridge or a bony bridge. If it's a sick physis but there is no bony bridge, the treatment is standard. You do a hemiepiphysiodesis and then see what happens. If there is a bony bridge, the question now, is it resectable or is it non-resectable? And we have seen that with the mapping of the bar, you decide whether you are going to resect it or not. The second thing is there is a deformity or no deformity after you decide whether to resect it or not. If there is no deformity, then you resect the bar and you observe. If there is a deformity and you can resect the bar, then you do a hemiepiphysiodesis and then see what happens. The other thing now, if the bar is not resectable, if you have a non-resectable bar, there are 3 things that guide your treatment. Number 1, you have to correct the deformity if it is present. Number 2, you have to maintain your correction through skeletal growth, otherwise the deformity will come back, and then you lead with the limb length discrepancy. How you correct the malalignment of the deformity, there are 3 ways. The first thing, you do a acute correction with fixation, or whatever you want. You can do it with a plate, with a nail, with an external fixator. But the first thing, you correct the deformity acutely. The second option that you have, you correct your deformity using a gradual correction with an external fixator. And the third option, you calculate what your LLD will be at skeletal maturity, and then you do your correction of the deformity and the LLD at the same time using an internal or external fixator. So you have corrected the deformity in case you cannot resect the bar. That's the first thing. Number two, you have to maintain your correction until skeletal maturity. If you don't maintain your correction, the deformity will come back. How do you maintain this correction? By doing a hemiepiphysiodesis of the other side of the bone. And that's a must during the same setting as you do your correction. The third thing that you have to do now is deal with the LLD, and that you have a whole choice. It becomes how do you deal with the LLD. If it is the patient now is skeletally mature, you deal with it with an intramedullary device. So I think this algorithm helps the decision making and helps the way we think. I think it can be applicable anywhere in the world. I just have time for two examples quickly. We have a 4-year-old boy sustained trauma to the left ankle. He presented with a partial growth arrest in the distal tibial physis. There is no deformity. And by doing a CT scan, MRI, your calculation, you think that the bar is resectable. So what's the next step according to the algorithm? If you go to the algorithm, there is a partial growth arrest. There is a bony bridge. The bony bridge is resectable. There is no deformity. Therefore, what do? You resect the bar and you observe what happens. That's what was done. We decided to resect the bar according to the standard technique. We opened the metaphysial window here using minimal trauma, irrigation lots of the time, the mirrors, all the standard technique. The bar is resected. We put a substances, usually we put fat. We put a marker to measure if it grows or not. And 1 year follow-up, there was success in the bar. The patient is growing normally without any deformity. Second example, we have a 10-year-old sustained an injury at the age of 3 years, and there is an LLD of 6 centimeters. And if you look at the X-ray on the right-hand side, this is the bar that you have. It's huge central bar occupying 60 or 70%. There is a varus angulation, and there is a LLD of 6 centimeters. So we go back to the algorithm. We have a partial growth arrest. We have a bony bridge. This bony bridge is not resectable, and we have a deformity. We apply the 3 principles that we know. We correct the deformity, we maintain the correction, and then we deal with the LLD. So the option that we chose is to do an acute correction of the deformity, continue the hemiepiphysiodesis, and then we did the lengthening. By looking at the case, that is the case. So we did an acute correction, a bone grafting here, and we stabilize it with a sort of a cobra plate. You can see that the ankle joint here is parallel to the floor, and we continued the epiphysiodesis that was done before of the fibula, and we did the contralateral hemiepiphysiodesis. And the deformity was corrected here, and then we did a precise nail lengthening to correct the LLD, and that's the final result. We have this one. It's a 13-year-old. She sustained a growth arrest of the proximal tibia here, giving a typical recurrent deformity and an LLD of 3 centimeters. Calculated the bar. The bar is non-resectable. So again, we go to the algorithm, partial growth arrest, bony bridge. It's not resectable, and we apply the 3. This time, we chose to correct the LLD and the recurrent deformity at the same time using an external fixator. We continued the hemiepiphysiodesis to maintain the correction. And that's what was done. We have this, that the X-ray on the right showed the gross plate arrest. We applied the circular fixator. That's the standard laser fixator. And we lengthened and corrected the deformity at the same time, giving this final result. The last one, it's not yet, I have to put it in the algorithm, I don't know how, but this is a patient who sustained an injury. There is a bar, a central bar, you can see it here. There is no deformity, the patient continues to grow. What do you do? The advice and what we plan to do is, even though there is no deformity, we would like to resect it, otherwise it will lead to an intra-articular pathology. So the take-home message, all gross plate injury may lead to partial or complete gross arrest. Early diagnosis, extremely important. We think that this algorithm facilitates the planning and the decision-making. If there is a partial gross arrest and there is a bony bar that is non-resectable, we have to address these three problems: the deformity, maintain the correction, address it. Follow-up is extremely important. The last question that I have, and I will leave it to discussion, can we prevent gross plate arrest? Thank you for your attention. And thank you for inviting me.
Thank you very much, Professor Lee. Now we finished our first session during this night webinar, and we start the question rapidly, starting to Professor Patricia. There is a question: is there any special consideration during cast application or during application of the cast for proximal third fracture femur?
Well, what I think is that you have to reduce the fracture. So if the fracture is more proximal, you need to have more flexion and more external rotation. You do have to reduce the fracture.
Yes.
So everything depends on the reduction.
Okay, thank you. I want to ask you one question about the fracture femur in children. What is your plan if the child has fully traumatized child and he has had the head injury and his general condition require to postpone any surgical or orthopedic intervention? Do you prefer if the child is 2 to 4 years of age and has shortening and malrotated distal femur and starting to do soft callus? Do you prefer to open him or leave him and later on doing osteotomy?
This is for me.
Yes.
I think you have to put the patient, stabilize the fracture as the best you can do, depending if this is a polytrauma patient. Sometimes with head injury, if the child is in coma for a long time, it's hard to maintain. But you have to stabilize the better way you can. So I don't think you have to do any kind of osteotomy too early. I think you have to try to reduce the best you can.
Okay, thank you. Next, I will shift two questions to Professor Pierre. I only had one comment on the fixation of the fracture head radius. It is not easy job to reduce it through this flexible nailing. You agree with me? And it is better to do an close reduction and wiring, or even if it is not reduced, I will proceed for open reduction and fixation. But it needs very skillful hands to do it by flexible nailing. You agree with me? Or
yes,
not?
yes, I agree with you. So it is only for the radial neck fracture, right?
Yes.
Yes. Okay. Usually, we need to use some very precise technical points, because the first point is to use a steel nail, not titanium, because a steel nail for the radial head fracture is more rigid. And when you rotate the nail, if you use titanium, it's too elastic, and the risk is to lose the reduction. First point, use steel nail for the radial head fracture, radial neck. The second point, sharp nail, because the bone is very strong as a cancellous bone, and you need to impact the tip into the bone. The third point, in case of very severe displacement, like probably more than 40 or 50 degrees of angulation, we can use a pin through the skin to push the head, not like a Caponghi method, not under the head, because under the head you have the periosteum with the vascularization of the head, and if you put the pin under the head, you have a high risk of destroying the vascularization of the head. And it's better to push the head through the skin directly on the head, not under the head. And if you push the head with a pin, you can use the flexible nailing just to try and to begin mild rotation and mild reduction, and you try to rotate again 1, 2, or 4 times with a hammer, with a very mild rotation, and using progressive pronation of forearm to improve the reduction of the radial neck. So you need to take your time.
I need to be skillful and well trained for this manipulation here, right?
Yeah,
so
right.
Not advice for any surgeon. How you can do what you know to do, right?
Yes, okay. I agree.
Yeah. Okay, last question for you. What is about the indication flexible nailing in Montigia and the Galeazzi variants of forearm fracture children?
So for Montigia fracture is very easy because you need to, it's the only fracture you can put the nail through the alecrodon, through the physis of ulna, because you need to use a big nail with a very large bending to restore the curvature of ulna, for stretching the anterior membrane, for reduce the radial heads.
Okay, thank you, Pierre. We have no question for Professor Vergal, but Professor Rigi, we have one question for you.
Yes.
Just wonder about using bone cement to fill the gap after exciting the physial bar. What is your opinion about that?
We have never used it. We use the fat. Cement is being used in children in many cases to fill bone cysts, bone thing, and it is being used. So I think that's your choice, your dealer's choice. I don't know of any study that really compared all of them, but certainly it's an option.
Yeah. You have any experience, or you do the resection of the distal physial bar of the distal tibia arthroscopic by arthroscope, or you should open?
We always do. I mean, number one, they are very rare. Like we see it like maybe once every year, once every 2 years. But we open a metaphysial window. We calculate the, I mean, I'm talking about the central bar. The peripheral bar, obviously, yes, it's easy. But the central bar, we open the metaphysial window always, and we used a small mirror, lots of irrigation. We have never used a scope, although there are scopes with various angles, acute angles that you can use. But it was always for a metaphysial window. But arthroscope was reported, yes.
Thank you very much, Professor Rigi.
Thank you.
Thank you. All my professors will shift to second. Yes,
I have a question for Fergal.
Yes, please.
Fergal, if you have a defect, you know, you have an open fracture with a defect 10 centimeters, 12 centimeters. Do you do corticotomy at the same in the same stage? Corticotomy, osteoplastic procedure, and everything at the same stage?
I tend not to. What I tend to do is I tend to concentrate on the zone of injury first, but I'll put an external fixator on which is competent for doing a transport later. So I'll build it to do a transport, but I won't do the corticotomy until I'm happy with the soft tissue cover from the actual zone of injury. It's a person, there's no science to this. What I don't want to be is in a position of having done a corticotomy and then not being able to use it because I've got problems further down. And, you know, I don't know, especially in an injury that you describe, which is a very significant zone of injury, I'm not confident enough that that will allow me to start moving bone before the corticotomy heals. So I will routinely do that as a staged procedure.
Thank you. Thank you.
Dr. Nabil, can I have a comment?
Yes, please, Hassan. Yes, of course.
Concerning the question you asked, Dr. Patricia, you said that when we have a polytrauma or multiply injured child, what we have to do if we had the soft callus. I think in polytrauma child, we should go very aggressively and rapidly to fix the fracture very early for the well-being of the child. If we have a head injury or a concomitant chest injury, fixing the fracture very early is mandatory to maintain the life of the child. It's not acceptable to say that a head injury is a contraindication to anesthetize the child with a fractured femur. That's why we're not supposed to wait until we have this soft callus. Am I right, Professor Patricia?
Of course, I think you do have to stabilize with traction or external fixator, or sometimes you need to do internal fixation. Yeah. You do, the head trauma is not a contraindication for stabilization of the fracture, of course. And you make it easy to care, even in ICU care for the patient,
yeah.
Of course.
Because it's that we commonly face this problem in our country. Most of the anesthesiologists refuse to anesthetize a child with head trauma, which is in contrary that the child needs. He needs to fix the fracture to have a better outcome of his head injury. Statistically, children with head injury or chest injury and long bone fracture, when the fracture is fixed, they can pass the head injury. If not, because the head injury has very bad effect on the fracture and the fracture has bad effect on head injury. Moving the fracture increase the intracranial pressure and cause more drastic effects. That's why we're not supposed to have this soft callus. A polytrauma child or with head injury or chest injury especially should be fixed very urgently, and even if it's a case for conservative treatment, we shift to internal fixation or external fixation.
Of course, if you have a polytrauma, it's very important. You need to have specialized anesthesiology to really deal with these patients. But I agree completely. You do have to stabilize. Wherever you have to do, you have to do.
Yeah, thank you.
And I agree with you, Hassan and Professor Patricia, about that. And we should be coordinating with the anesthesia. That life-saving is more better after fixation of the fracture. Yeah. This is your message, Hassan, yeah. Right?
Yes.
Yes, okay. Thank you all. If anyone has any comment for first session. Okay, great. Now I will shift to Professor Federico. He's the General Secretary of the EPOS, and he has talking about the proximal tibial fractures in children, and then about the Mcfarland fractures. Yes, Professor Federico.
Thank you. Yes, I have uploaded the talk as well. One, two, three, four, five. I would like to thank the Egyptian Orthopedic Association and Gamal Hosni for his kind invitation. Tonight I'm going to talk about Mcfarland fracture, which is a severe growth plate injury. Mcfarland fracture originally stands for a Solteren-Harris type 4 fracture of the medial malleolus. However, over time, the definition is slightly changed, and today, for Mcfarland fracture, we mean the association between a medial malleolus fracture, Solteren-Harris type 3 or 4, together with a lateral malleolus fracture, Solteren Harris type 1 or 2. Mcfarland fracture are usually caused by a supination inversion injury and usually affect the children between 8 and 15 years of age. The key issue driving the surgical or conservative management of Mcfarland fracture is the amount of displacement. And the key number to keep in mind is 2 millimeters. Today, we agree that if displacement is less than 2 millimeters, conservative treatment is possible. However, this threshold is quite rare. And also it is important to highlight that planar radiograph tend to underestimate the amount of displacement. And usually a CT scan is necessary in order to clearly assess the amount of displacement and take the decision to operate, whether you perform surgery or not. In any case, if following CT scan assessment, the amount of displacement is less than 2 millimeters, then you can aim for conservative treatment. And usually, immobilization lasts for 6 weeks. The first 3 weeks, the patient is immobilized in a long leg cast, whereas during the second part of the treatment, from weeks 4 to 6, the patient is in a short leg cast. However, if the amount of displacement is more than 2 millimeters, which is the most frequent case, surgical treatment is necessary in order to achieve an anatomical reduction. And you can perform percutaneous closed reduction and percutaneous fixation, or open reduction and fixation. And whatever the surgical technique you apply in your patient, the outcome is likely the same. Today, there is also the tendency to do surgery in all Mcfarland fracture because this threshold of 2 millimeters has been lowered to 1 millimeter only. In any case, if following your reduction maneuver still persists a displacement more than 2 millimeters, then you have to suspect periosteal and or soft tissue interposition. And in this case, you have to perform an open reduction because the insufficient reduction increases the risk of growth arrest in this patient by more than 3 times. How to achieve, how to check the quality of your reduction. This is a trick that I found very useful because I tend to operate all these injuries by closed reduction and percutaneous fixation. And then by performing an intraoperative arthrogram, you can assess the quality of your reduction without opening the joint. Mcfarland fracture, as you all know, are intra-articular epiphyseal fracture that carry an increased risk of degenerative arthritis. They are at risk of growth arrest, and usually the outcome is poor if conservative treatment is performed. These fractures also have a high rate of complication, and in particular, growth arrest can occur in up to 40% of patients. And most of these growth arrest leads to varus deformity, lower limb discrepancy, and in some cases, there can be an associated tibiofibular synostosis. And in all cases, if reduction is poor, as you can see in these post-operative images, the risk of degenerative arthritis is quite high. Secondary deformity are quite frequent because the remodeling potential of the distal tibia is low, and for this reason, these patients do not have a lot of opportunity to spontaneously remodel an imperfect reduction. So in conclusion, Mcfarland fractures are fractures at high risk of complication. Surgery is usually recommended if the gap is more than 2 millimeters, even though today some surgeons do recommend to perform surgery in all cases, and they lower this threshold for surgery down to 1 millimeter. Remember that even if you perform an anatomical reduction, you cannot prevent the growth arrest from occurring because this injury, being a Solteren Harris type 4, injury of the medial malleolus damage the germinal cells of the growth plate. This patient, as you may expect, requires careful radiography and clinical surveillance because you want to be able to detect potential epiphysiodesis early. You want to avoid as much as possible the occurrence of growth malalignment, and you need to follow this patient carefully until the end of growth. If a complication occurs, if you have a malalignment, if you have a secondary deformity, surgical correction of this deformity is possible later at skeletal maturity, and usually this surgical correction provides a good outcome. Thank you very much for your attention.
Thank you, Professor Federico. You can shift to next talk. Khaled.
Good evening. I'm Federico Canavese again. I'm going to talk about
You are muted.
بعد البرزنتيشن انا نبيل ماشي.
اوكي الثانيه جايه.
fracture of the proximal tibia. So I organized this talk a little bit differently from the previous one, and I'm going to start with a clinical case. Here we have a male, 12 years of age. Mechanism of injury was a bicycle accident, trauma of the right proximal tibia with swelling at the level of his right knee. These are the radiographs upon arrival at the emergency department. What would you suspect? You think radiographs are enough? Or you think you need more investigation like an MRI or a CT scan? In this case, a CT scan was performed. So these are the pictures. And what is your suspicion? What is your diagnosis? So you suspect a tibia eminence fracture, anterior tibial tuberosity fracture, tibial shaft fracture, or Solter and Harris type 5 fracture. So in this case, the surgeon selected closed reduction and long leg cast immobilization for this patient. Do you agree or disagree according to the post-treatment radiographs? So after 6 weeks, cast was removed. What next? Do you think you can discharge the patient? You don't need to see this patient again. You need to see this patient regularly because non-union is a significant risk. You need to follow this patient because the risk of growth arrest, in particular valgus deformity, is important. Or you need to see this patient regularly because recurvatum is a risk of growth arrest is significant. So the patient was discharged and he comes to see you again 6 years later with those radiographs. What is your diagnosis and what would you do next? These are the clinical picture. So do you think no intervention? You think you have to suggest a guided growth, or you have to correct the deformity by some sort of osteotomy and fixation? So in this case, we decide to perform an acute correction with plate fixation. And this is the clinical outcome after surgery. So I introduce you to this to fracture of the proximal tibia by this clinical case because I want to point out immediately, right from the beginning, some key points. These are rare fractures. These fractures are potentially dangerous, and these fractures are at risk of growth disturbance. Tibia can be the site of multiple injuries. However, proximal tibial injury are much more infrequent than tibial shaft fracture, which represent about 5% of all pediatric fractures. Proximal tibial fractures, on the other hand, are only 5 to 6 cases over 100,000 injuries, and are usually secondary to high energy trauma, in particular sport accident in 47% of cases, or motor vehicle accident in about 30% of cases. I'm going to talk about proximal tibial injury according to the anatomy, starting from the epiphyseal injury down to the metaphyseal fractures. So if we start from the epiphyseal injury of the proximal tibia, these are mostly type 2 according to the Salter and Harris classification. These kind of fracture are quite rare, but they occur because there are very few ligaments that are directly attached to the epiphysis. The collateral ligaments are not attached to the epiphysis, but in any case, varus and valgus forces can be transmitted to the distal femoral physis, the fibular head, or the tibial metaphysis, as you can see by these pictures. Proximal tibial physial fractures are secondary to direct and indirect trauma, and they are always secondary to some hyperextension force that displays the tibial metaphysis posteriorly. And this is quite important because they can be source of vascular lesion because of vessel tethering. This is because the popliteal artery runs very close to the proximal tibial metaphysis, and also right at the level of the epiphysis, the popliteal artery gives off the genicular branches just after the trifurcation of the tibial artery that penetrates the interosseous membrane. And here on this CT scan picture, you can see how close are the vessels to the bone. So you can imagine that the posterior displacement of the metaphysis of the tibia can kink the vessel right at this very specific anatomical region. And so for this reason, careful analysis of the distal pulses is mandatory, and also you have to repeat, I will tell you this again later, the vascular examination during the first 48 hours after injury. And these fractures are at risk of growth disturbance because they occur around an active growth plate, and also they happen around the growth plate that doesn't close simultaneously, because the proximal tibial growth plate, which is L-shaped, closes first from back to front and then from proximal to distal. And of course, if you don't damage the proximal growth plate, the remodeling potential of the proximal tibia is quite significant compared to the shaft or to the distal tibia. So in case of proximal epiphyseal tibial fracture, you can have different treatment modality. Non-operative treatment is for non-displaced or minimally displaced fracture, usually is reduction under general anesthesia and casting. In some cases, internal fixation may be needed, especially in Salter and Harris type 1 and 2 that are not stable enough after a reduction. In this case, you can use smooth key wires and apply a cast for 4 to 6 weeks. In some cases, open reduction may be needed, in particular in case of Salter and Harris type 3 and 4, when you need an anatomical reduction because these are intra-articular fracture. You can fix the fracture with screws, and cast is needed for 4 to 6 weeks. Complications of these injuries are significant. You can have, as I mentioned before, injury to the popliteal artery in up to 7% of cases, and in this case, it's important to check and to repeat your vascular examination during the first 48 hours from tarman. In case of absent or peripheral pulses, at the emergency department, you have to do an immediate reduction, and if after your reduction pulses do not return, then you have to explore the fracture in the OR. These fractures are at risk of compartment syndrome and are at risk also of growth disturbance. The other group of fracture are the anterior tibial tuberosity fracture. These fractures are classified according to the Watson-Jones classification: type 1 undisplaced, type 2 displaced but extra-articular, type 3 displaced and intra-articular. There is an extension of the original Watson-Jones classification where two subtypes for each class have been introduced, A and B, and it means that you have multiple fragment is type B, just one fragment is type A. And here you have some radiographs of type 1, type 2, and type 3 anterior tibial tuberosity fracture. As I said, these injuries are rare, potential growth arrest, and risk of growth disturbance that is increased. Here the case that we discussed previously. In this case, the patient was not followed up, was lost to follow up for a period of about 6 years, and this is the outcome. So for this patient, regardless of the treatment modality, you have to make sure the patient are regularly followed. And in this case, as I mentioned before, we did perform an acute correction by osteotomy. However, for the same complication, treatment by external fixation is also possible in order to restore a correct alignment. Then we have the tibial eminence fracture. Tibial eminence fracture are classified according to the Meyers and McKeever classification: type 1 undisplaced, type 2 mildly displaced with a posterior hinge that's still present, and type 3 severely displaced. In 1977, Zarikny added one class, the type 4, which is the comminuted type fractures. Here are some radiographs about tibial eminence fracture. We have the type 1, type 2, and type 3, as you can see here. So tibial eminence fracture should be considered as a sort of ACL equivalent injuries, and surgery is recommended in case of displacement. It is important to keep in mind that sometimes reduction is not possible because you have meniscal and intermeniscal ligament interposition that act as a barrier to reduction. And the other important point is that usually these injuries end up in ACL rupture in adults. However, in children, the ACL tend to stretch, but it doesn't break. What breaks is the bone. However, the ACL can get some residual laxity. Usually, this laxity is rarely clinically significant. However, in some cases, ACL reconstruction may be needed later in life. In any case, tibial eminence fracture can be treated conservatively with the knee in extension, long leg cast, of course, in case of non-displaced fracture or minimally displaced. In case that are displaced but can reduce with the knee in extension, you can treat this fracture conservatively. However, in case type 2 do not reduce with the knee in extension or severely displaced fracture, surgical treatment is required. This can be open or arthroscopic, and you can fix the fracture with screw or suture, and whatever the treatment and whatever the hardware you use to fix the fracture, the outcome is similar. Again, immobilization is always in extension with a long leg cast for 4 to 6 weeks. One complication of conservative or surgical treatment of such injuries is arthrofibrosis, and in this case, manipulation under the general anesthesia may be required. However, you have to be careful that if you are dealing with a patient that is still with open growth plates, you can cause, by the manipulation, distal femoral physial fractures. And then we are going to talk about metaphysial fractures of the proximal tibia. These fractures occur in much younger children. The peak is between 3 and 6 years of age. These are typically incomplete and stable fracture, and the mechanism of injury is a valgus force across the knee. These fractures, because of the type of injury, tend to evolve towards a transient valgus deformity. This is the cosent phenomenon, which is caused by an asymmetric stimulation of the upper tibial growth plate. For this reason, this fracture requires a varus mold above knee cast in order to prevent the valgus deformity. The valgus usually tend to remodel over a 12 to 24 months. However, in rare cases, hemiepiphysiodesis or corrective osteotomy may be required. These fractures, in most cases, are treated conservatively. In some cases, you require surgical fixation, mostly in older children, and in even exceptional cases, you may need to perform open reduction in case of interposition of the PES. Another category of fracture, which is quite infrequent in children, is the tibial Petrol fracture. These are always high energy trauma, and these kind of fracture are always comminuted. You have to try to be the least aggressive as possible in this fracture, but to understand the fracture and to plan the correct treatment, you always need to perform a CT scan assessment, and you have to try to achieve an anatomic reduction and stable reduction by internal fixation. However, these fractures are at high risk of growth arrest. So in proximal tibial fracture, you have to be careful. You don't have to assume that remodeling will consistently or reliably correct all the deformities, and you have to be vigilant to anticipate the potential complication. And also, every time you have a patient that comes that is admitted for a proximal tibial fracture, mostly epiphyseal fracture of the proximal tibia, you always have to check the distal pulses and to repeat your vascular examination during the first 48 hours from trauma at least. Remember, the children that are 10 years of age or less have the highest remodeling potential, that the remodeling potential is more reliable in the plane of the joint motion, that metaphyseal fracture remodel better than the diaphyseal, and remember that metaphyseal fracture can be source of valgus deformity according to the Cosen's phenomenon. Don't expect rotational deformity to fully remodel, and remember that in tibial proximal fracture, some overgrowth can occur, but is not predictable. And this is the very last slide with the take-home message. Tibial eminence fracture, you can treat by cast those that are not displaced, or fracture that are mildly displaced that reduce with the knee in extension. All the others require surgical treatment. Same for anterior tibial tuberosity. Undisplaced fracture is long leg cast, whereas displaced fracture type 2, 3, A, and B, if you also apply the subcategories, require surgical treatment. Metaphyseal fracture usually can be treated by a cast, by conservative treatment. However, older children and severely displaced fracture or a fracture with soft tissue interposition may require some surgical treatment. An epiphyseal fracture, remember that undergo cast treatment only if they are undisplaced or minimally displaced, and in any case are still stable after closed reduction. On the other hand, all fracture that occur in older children that are undisplaced and that are unstable or displaced, or fracture that affect that are intra-articular, then requires surgical treatment. So remember that casting is not the gold standard for all tibial fracture. You have to select the right treatment option according to the type of the fracture, to the age of the patient, and to the amount of displacement. Thank you very much for your attention.
Very much, Professor Federico, for your nice talk. And we will postpone the question till after finishing our speakers. Now we shift to different lines of treatment of fracture lower limb in children in general. We'll start by Professor Osama Higazi, godfather of pediatric orthopedic surgeon. And he will speak about the conservative lines of treatment of fracture lower limb in children. Although it is too late night in Egypt, I told you that we have more than near to 500 attendees attending our webinar tonight. هذا دكتور اسامه بيه. Unmute يا بيه. Unmute يا بيه. دكتور اسامه حضرتك عامل ميوت على الصوت.
طب كده خلاص.
تمام يا ريس.
Okay. It's good evening. It's a pleasure to take part in this successful scientific webinar. I'll give a very short talk about conservative treatment of pediatric lower limb fractures. Conservative treatment, when and how to do conservative treatment in pediatric lower limb fractures. This could be answered by decision-making based on age of the patient, fracture pattern as regard type of fracture, appropriate reduction and range of acceptability, presence of associated injury or multiple trauma, risk and benefits of each treatment method. Most pediatric fractures can be treated by non-operative methods under the age of 8 years, as we see in this figure. Treatment principles of closed methods are reduction and immobilization of cast are those two basic principles in treating fractures by closed methods. But there is another two important factors or two important principles. Closed follow-up to check alignment, it's very essential, and loss of reduction consideration. In some cases, there is loss of reduction, and this should be put in consideration and consider remodeling and other factors, as we will see. Those factors are most important and most key of success in conservative treatment, which are the close follow-up to check the alignment and loss of reduction considerations or range of acceptability in pediatric fracture are two major principles in conservative treatment of pediatric fractures, most important steps and key of success for treatment of pediatric fractures, especially lower limb by closed methods. We will start by femoral shaft fracture. There is algorithm or guidelines of American Academy of Orthopedic Surgeon guidelines about treatment of femoral shaft fractures, and is still valid till now. There's no changes in this treatment algorithm or in this treatment guidelines. We start up to age of 6 months. We apply pelvic harness or spica cast. From 6 months up to 5 years, we apply spica. If there's a shortening less than 2 centimeters, or if shortening is more than 2 centimeters, we apply traction, then spica. From 5 to 12 years, if the length is stable, prefer flexible nails. If length is unstable, plate, either bridge or open plate. After age of 2 years, length is stable. The preferred method is intermedullary nail lateral entry, or if the body weight is less than 50 kilograms when we use elastic nails. If the lens is unstable, plate or submuscular plate is the preferred method. Of age of 15 years, intermedullary nail lateral entry. In polytrauma patients, consider external fixation. This is the American Academy guidelines for treatment of pediatric femoral shaft fractures. If we look to this, this is a level of evidence for those methods. We see the immediate or late spica cast, if 2 centimeter shortening, have a very good level of evidence, and this supports the conservative treatment at that age group from 6 months up to 5 years. This is the treatment algorithm. Up to 6 months, apply Pavlik harness or spica cast. From 6 months up to 5 years, apply spica cast alone if there is shortening less than 2 centimeters, or traction then spica cast if shortening is more than 2 centimeters. From age of 6 up to 12 years, we flexible nails, or if the lens is stable. In cases of the lens is not stable, we prefer plate fixation. After 11 years, that treatment of choice is rigid intermedullary nails or submuscular plate. The immediate spica cast, either single leg cast. When to do single leg cast, apply single leg cast in low energy trauma or age below 3 years. If the spica cast include the other side, when to do, we will do it in high energy fractures or age above 3 years. And this is X-ray, show a fracture, low energy fracture. It had been treated by one leg spica cast. This high energy fracture, it will be treated by spica cast, including the other side. An immediate spica cast done in hip and knee in 40 to 45 degrees of flexion. The foot out. Clinical can include opposite side if decided, as we said before. This is the position of single spica cast if had been used to treat recent fractures or recent femoral shaft fractures, hip and knee flexion from 40 to 45 degrees. The foot is out, and this is single spica cast. When immediate spica cast is not preferred, there are certain conditions immediate spica cast is not preferred, such as massive swelling of the thigh. This is contraindicated to apply immediate spica cast. We may need traction then followed by spica cast, or shortening more than centimeters. We need traction then spica cast, or associated injury. We prefer operative fixation. And this is examples of conditions which are not be treated by immediate spica cast. This is an example. A femoral shaft fracture had been treated by spica cast. The other side is included. This is the post-reduction X-ray, post-cast X-ray. And this is the final results after 4 months follow-up, complete healing with accepted position. Spica cast after traction is almost had been done in this position. There is no need to apply flexion knee and flexion hip. It's applied in slight abduction and slight flexion knee and hip. There's no need to do it in more in 40 or 45 degrees if it's applied after traction. Here, this accepted malalignment and remodeling in pediatric femoral shaft fractures, and this is walking spica cast. The child can walk with it, and this is very nice cast. This is very nice result. Accepted malalignment up to 30 degrees varus or valgus angulation, 50 degrees translation, and up to 2 centimeter shortening. This is accepted malalignment and remodeling. This is a case of fracture, femoral shaft fracture, had been treated by spica cast. There is shortening, translation, and angulation. And this is X-ray after treatment. Very good, very good healing, very good alignment after remodeling. This is a case of neonatal fracture femur, severely displaced. 8 months baby had been treated by simple immobilization, and this is the after 4 months after treatment, fracture united in a good or accepted position. This is remodeling of translation and shortening after femoral shaft fracture. This is fracture femur. There is shortening translation, and this is remodeling after treatment by conservative measures. This is 4 years old child. And this is the first X-ray, had been treated. And this is after 11 months. Very good remodeling for this femoral shaft fracture. This 8 years old child, and this is a process of remodeling in this condition. This is case received late. We wait and see, consider remodeling, and it's united in a good position with accepted position, and for further correction by remodeling. So the femoral shaft fractures up to 6 years old, there is no doubt to follow rules according to the American Academy guidelines, treated by spica cast, traction with spica cast, because this method is very safe. Remodeling will solve a lot of radiological malalignment, which is disappointing to the parents, and it needs a parent's reassurance from the start. Tibial shaft fracture. If we saw this study had been done for 5 years. In 5 years study, patients, the authors discussed 296 patients for final treatment of femoral tibial shaft fractures. They found cast had been applied for 140, manipulation and cast for 66 cases, flexible nail for 52 cases, rigid nail for 21 cases, external fixation for 14 cases, and plate for 3 cases. And this magnifies how tibial shaft fractures could be treated by conservative measure, and treatment is successful in those number of cases. Treatment algorithm for pediatric tibial shaft fracture. A non-displaced fracture, we apply long leg cast for 6 to 8 weeks. Repeat radiograph weekly to check alignment. As this case, this is non-displaced fracture, just need to apply a well-molded long leg cast for 6 to 8 weeks, where regular follow-up to X-rays to check the alignment. If displaced fracture, displaced stable fracture, it needs reduction and long leg cast. This is displaced fracture, displaced stable fracture. It requires close reduction and apply well-molded long leg cast for from 8 to 12 weeks with weekly checkup to check the alignment. In displaced unstable fracture, from the start to apply reduction and fixation like this. This is cast immobilization. It is the commonest in tibial shaft fracture, as we see. Accepted alignment for the physical tibial fractures. Pediatric fractures don't have too much potential for growth. So tibial shaft fractures, we accept too small amount of shortening, not more than 5 millimeter in up to 5 years, not more than up to 5 millimeters after age of 5, from 5 to 10 millimeters from till the age of 5. Don't accept more than this because there is very weak potentials for remodeling in tibial shaft fractures. الريكارفيتم or sagging you accept less than 5 degrees. والvarus or valgus angulation you accept less than 5 degrees. So there's limited range of acceptability in tibial shaft fractures. This is a 9-year-old girl, displays stable fracture, displays stable as we show in the algorithm, had been treated by close reduction and well-molded long leg cast. And this is very nice position. This is 7-year-old girl had been treated by well-molded cast, and so the final results very good position. This is 6-year-old boy. This is fracture has been treated by barto reduction and a long leg cast. This is 9 months after treatment. Isolated tibial fractures with intact fibula, it needs some precautions because there is tendency of varus alignment with intact fibula. So treatment in these conditions requires some precautions. Fibular fractures, fracture tibia with intact fibula results in varus angulation. If a valgus molded long cast is preferable. Valgus molded long leg cast, because wedging of the cast in these conditions is difficult because intact fibula. So from the start, try to apply traction, to correct the alignment, and apply valgus molded long leg cast to counteract the tendency of varus angulation in such a fracture. Wedging of cast tibial shaft fractures could be used to treat some angulations, because as we said, the range of acceptability of angulation in tibial shaft fractures is not more than 5 degrees because there is poor remodeling potentials. So wedging of cast can solve the problem to avoid to do unneeded surgery in such conditions. That simple wedging of cast will correct the malalignment and reduce the angle of reduce the angulation and can achieve better results. Geometry of wedging, you have two types of wedging of cast. Wedging, as we learned before, to do wedging of the cast opposite the fracture side. There is a recent study. You do wedge far from the fracture. This is need small movement of the cast to correct the angulation. This is angulation and this is the angulation. He did wedging here. He needs a small amount of movement of the cast to correct the angulation. If we do the wedge opposite the fracture side, we need a very wide movement of the fracture to correct the angulation. So this wedging far from the fracture side is much mechanically and less risky for the skin, because we need to move the cast in very small amount, like this. This is a 5-year-old girl of tibial shaft fracture, treated by wedging of cast, and this is an improved alignment. In older children, the long leg cast can be converted to a patellar tendon bearing cast after a period of 3 weeks, and this is very functioning and very easy for the patients to overcome the unneeded, the bad expectation of the long leg cast. It's a very good solution, get better results for tibial shaft fracture. This is the remodeling in tibial shaft fractures. Delayed valgus angulation occurred in proximal tibial metaphysial fractures, and this delayed angulation it's an expectation for such a fracture and should be considered in dealing with the parents from the start. But under the age of 5, partial spontaneous correction occurred. So in these situations, proximal tibial fractures, even if it's not displaced, may develop delayed valgus angulation. Treatment in such condition is wait and see for 1 year. If it's not correct, we shift to correction by osteotomy. Ankle fractures, pediatric ankle fractures is not uncommon. It's common. It presents about 5 of all pediatric fractures, 15 to 30% of all physial injury in children. It's the most common physial injury of the lower extremity is pediatric ankle physial fracture of the lower ankle, tibia and fibula. Age from 8 to 15 years. How common and how they occur? They occur from torsional injury. Like in here, you consider Salter Harris type 1 distal fibula fractures are the most common ankle fractures, but they are often misdiagnosed as ankle sprain or rarely missed. Here, this condition is very common, that it's very commonly to be misdiagnosed or has been not treated. Tenderness here will be located directly over the lateral malleolus rather than the tibial ligament. As we see in this condition, this is the physial physis of the distal fibula. Injuries here may occur in physial separation. Tenderness will be at the distal fibula, and this may be misdiagnosed or diagnosed as a sprained ankle. Salter Harris type 1 distal fibula, it's a common injury, but it's commonly misdiagnosed or undertreated. The most common ankle fractures, they are often misdiagnosed as an ankle sprain or rarely missed. A fracture may not be evident on X-ray. The diagnosed clinically with localized tenderness above the distal fibula rather than the lateral ligament. And Salter Harris type 2 and 3, the most common physial injury, type 2, 3, and 4 are the most common physial injury distal fibula. And it's discussed in the lectures.
Yes, Professor Osama, الانكل, Professor Federico and
ما يعني
خلاص
Prince Rabi.
Okay. Okay. We consider treatment of lower limb fractures, femoral, tibial, Physial fracture and physial fracture are discussed before, so we can stop at that point. Thank you.
Thank you very much, my dear Professor Osama, for your presentation. And now we change our mind from the conservative treatment to the surgical treatment and the internal fixation. And this will be presented by Professor Hassan Al-Barbari. Hassan, give us about your experience and your ideas about the indications and pitfalls of internal fixation for the fracture lower limb in children.
Good night, everybody. Thank you, Professor Dr. Gamal. I'm really very lucky to be with this distinguished panel. It's hard to talk after Professor Dr. Osama and just before Professor Dr. Gamal, but I just try to be concise and in time. Internal fixation of pediatric fractures of the lower limb. First, we have to talk about the power of remodeling and the union power, which is something distinguished for children. Children can tolerate conservative measures much better than adults. That's why we don't have to rush for internal fixation. We have to think about the Salter Harris classification, that we have a complete difference between type 1 and 2, where physial growth arrest is really rare, while in Salter Harris type 3 and 4, we should have good anatomical reduction. The age of the patient and the mode of the trauma plays a lot concerning the method of the treatment. The children bones are completely different. That's when we have the child bone, we have the thick cartilage. When we see on the X-ray just a small fragment of bone, it's covered with a huge, our big sized cartilage. The thick periosteum, which is metabolically active and it helps a lot for the treatment. It could be used as a method of internal splint during the conservative treatment. Having more collagen and more cancellous bone, this we see in children different types of fractures, like the plastic deformation or the buckle or the fracture. The ligamentous injury, as stated by Professor Federico, causes bone to fail instead of the ligamentous failure. Having the growth plate, which helps a lot the child because it causes the remodeling during the growth. Hence, if it is broken, if the disc itself is broken, it may cause to growth arrest. We have to think, does the same rules that apply in adults apply in pediatrics? Of course not, because as I said, they have good healing power and they have the power of remodeling. Okay, like Professor Federico stated, that the power of remodeling depends on the age, on the growth potential of the adjacent physes, and the proximity to the physis itself, and to the motion or the plane of the deformity and its relation to the motion of the nearby joint. We have to do internal fixation. Generally, when we lose the power of remodeling or we get near the age of closure of the physial growth plate, if we have Salter-Harris type 3 and 4, or if you have an interarticular fracture. These are roughly the absolute causes of internal fixation. But in some fractures, we have to go for internal fixation, like in the fractures of the neck of the femur, to prevent lots of complications concerning the fractures of the lower limb. This is roughly when we have to do the internal fixation. In infants, fractures of the neck of the femur in the lower limb is the only indication for internal fixation. It's not forgiving, and we should have good or 100% anatomical reduction. If not, we should go for internal fixation. If we go to the child age, we add the injuries around the knee and injuries around the ankle, and complications. The injury in the femur is getting to, we can go to internal fixation also for fractures of the femur. In adolescents, it's more or less like fractures in the adults, but still the cast has a role in the fractures of the tibia. Again, this is the Salter-Harris classification. It should be very clear that in type 1 and 2, the physial disc is intact, and hence the complication is very rare. And anatomical reduction, we should search for it, but it's not 100% mandatory. But in Salter-Harris type 3 and 4, it's not acceptable to have a 1 millimeter displacement. Because if we have this displacement, the fracture hematoma of the epiphysis and the metaphysis will be into communication with each other, and a bony bridge may happen, and this is the cause of the physial growth arrest and disturbance in growth in later time. That's why type 3 and 4 should be anatomically reduced 100%. The method of fixation in children is completely different from what we're used in adults. What are the implants commonly used in pediatric fractures? We use K-wires, like in fractures of the distal femur. We may use intramedullary fixation, as stated, for the diaphysial fractures, whether in the femur or in the tibia. We use leg screws for physial injuries, whether metaphysial or epiphysial, so Salter-Harris type 3 or type 4. We use plates, submuscular plates, for heavy children or fractures in the diaphysis where there is longitudinal instability and shorting when it's anticipated. We are not supposed to use flexible nails, but we're supposed to use the submuscular plates. Also in complex metaphysial fractures, and of course in fractures in the neck of the femur. The lateral anterior-femoral nail is now getting more popularity in fractures of the femur, especially near adolescents. When I revised the lectures, I found that most of the regions have been discussed, and I think I have to give a brief about the fixation of the femoral neck fractures. Fractures of the neck of the femur constitutes 1% of pediatric fractures. It's mostly caused by high energy trauma or low energy trauma in pathological bones. The Delbert classification stood the test of time. It's an anatomical classification where type 1 is the slipped capital femoral epiphysis, of course traumatic, not that of the adolescent type, the pathological scaphy. The type 2 is the transcervical. Type 3 is the cervicotrochanteric, and type 4 is the intertrochanteric. This classification is very useful because it dictates for us the prognosis. For type 1, it's the worst prognosis. Type 2 is a bit better prognosis. Type 3 and 4 carries good prognosis. This fracture is very commonly missed because it's, as I stated, it's most commonly due to high energy trauma, and concomitant injuries like the head injury or fracture pelvis or fracture spine is very common. That's why it may be missed. When we think about the protocol of management of femoral neck fractures, we adopt the advanced the urgent necrosis, the non-union or varus union, or the premature physial closure. As Delbert asked, historically, 100% of type 1 caused AVN, but now it's only 38%. In type 2, it's now 28%, and 3 and 4, it's about 10%. The risk factors for the bad prognosis is the type 1 and 2, as I stated, the older age and the initial displacement. The factors that change the prognosis to better results is that urgent treatment is mandatory, capsular decompression should be done in all patients, and we should adopt 100% anatomical reduction with secured fixation in all of the cases. As I stated, the complication other than the AVN is the Coxa-Vara, non-union, and premature physial closure. For Delbert type 1, we should do gentle reduction. If the femoral head is in the acetabulum, as in type 1A, it's okay. If not, we should attempt closed reduction. If failed, we should go for open reduction through an anterior approach, and fixation is through a 4 millimeter cannulated screws. In older children, we can use 4.7, for 4 to 7 years in age. Larger screws can be used, which is the 7 millimeter screw. Smooth pins is used in children less than 4 years of age. This is child with type 1. Of course, he had child abuse, as it's clear here, has also a healing distal femoral physial injury. In this age group, only closed reduction and casting is more than enough. In type 2, we adopt the same techniques. We should go for stable internal fixation after gentle closed trial of manipulation. If not reduced, we go through open reduction through the anterior approach, or we may use the anterolateral approach. And of course, we should go to threaded Steinmann pin or cannulated screws, and we should try not to bypass the physis. This is a case of type 2 child after fixation. Of course, spica cast is a must after this fixation. And in type 3 fractures, we adopt the same, but we should say that below the age of 6, we can go for conservative treatment only in a cast. In type above the age of 6, we should go in type 4. This
صوتي حاسس.
The distal femoral physis is very important to discuss. It's more or less the same like what Professor Federico talked about, the proximal tibial physis. It's a very rare injury. If it happens, we should search for the pulses. It's very common to have physial growth arrest even after proper treatment. That's why we should talk to the parents about this complication, which happens even with proper treatment. The algorithm for treatment for type 1 is closed reduction and K-wire fixation, because it's unstable even after closed reduction and anatomical reduction. This is the general algorithm of the treatment. For type 1, we use K-wires. For type 2, we can use the cannulated screws. For type 3, we use also the cannulated screws as in type 4. This child with type 1A, we did closed reduction and K-wire fixation. And for type 2, we use the cannulated screws. A tip here is that when we need to do open reduction, if it's not reducible, we should do the incision on the contralateral side of the metaphysial fragment. For the Salter-Harris type 3, we use 2 screws, and we should do a tunnel view to be sure that the screws are anterior to the Wildenstein line. Lastly, we should remember that physial injuries concerning type 3 and 4 should be anatomically reduced and internally fixed. We should know the rules of remodeling very accurately, when to anticipate remodeling and when not. We should do the indications of internal fixation in children. The more we go to adolescent, we more to go to the internal fixation. The methods of internal fixation in children is completely different from that in adult. We can use 2 wires or just 2 cannulated screws. And we should care for strict management of fracture of the neck of the femur and sorry for being late.
Thank you, Professor Hassan, for your nice talk. Lastly, we end our webinar tonight by presentation about the indications of external fixation in fracture long bones in children by Professor Gamal Hosni.
I know this is the last talk in this webinar. I hope it's going to be a fast talk. When I talk about the role of external fixation in pediatric fractures, are we talking the same language? I don't know. I've been invited to many meetings before, and every time I talk about the role of external fixation in fractures, I feel like I'm talking another language, and I will show you why. I want to remind everybody with the next meetings of the Egyptian Orthopedic Association. This is the clinical meeting with Banha University, next Friday. And we have our deformity conference from 4 to 6 August in Intercontinental City Stars Hotel. All of you are invited as usual, and I hope it's going to be not hybrid, face-to-face 100%, hopefully. Again, this is the MIPOS meeting, the Middle East Association for Pediatric Orthopedics. It's going to be from 14, 16 October. Again, you are all invited to this meeting. I know everybody wants me to talk about the indications, and everybody wants me to talk about that we have limited indications for external fixations, open fractures, polytrauma, neglected fractures, infected fractures. I'm sorry, I'm going to disappoint all of you. I'm not going to speak about these topics. So why? Let's be true. Why X-fix is not popular in pediatric fractures? Why? Why we have limited use of external fixation in pediatric fractures? Because we don't talk the same language. Why we don't talk about the same language? Which type of X-fix? What do you mean by X-fix? Remember that this cast is an external fixation. Wedging cast is an external fixation. And the experience. So when we talk about the X-fix, what do you mean by X-fix? Do you mean unilateral fixator? Do you mean lock the plate working as an external fixator? Do you mean circular fixator Elizarov? Do you mean this triangular pattern? This pattern? If you want to think about evidence-based medicine, remember that in the papers or the meta-analysis, they always group all these external fixators together. They are totally different, totally different. It's not one entity. We're speaking about totally different entities. I will show you how. Of course, we have many hardware limitations. I'm not going to speak about them. The second thing, why it's not popular? Because what do you mean by X-fix? In the literatures, depending upon the AO principles, X-fix for span, scan, and plan. And each, they have many courses and they teach the people span, scan, and plan. And they talk about evidence-based medicine and evidence-based medicine and evidence-based medicine. But this is non-evidence-based medicine. It's based upon nothing. Span, scan, and plan. It's just repetition of the same words again and again. So it's based on false evidence-based medicine. All the indications of external fixator are based upon false evidence-based medicine. The experience. Remember that most of the people teaching external fixator, actually, they are professional in internal fixation, not external fixation. And when they teach external fixation, they teach the residents that external fixation is putting 2 half pins above and 2 half pins below, and that's it. Remember that. So if you look at the American Academy and they talk about the fracture neck of fracture femur, and they have 2,646 fractures, operative treatment 44%, 2% of them, they treated the patient in external fixation, 50% in one center. On the whole states, they were using 1%. So if you look to the experience of each center, it's going to be 1 or 2 cases per year. Can you imagine? You give your opinion about something and your experience is 1 patient per year. So again, why XFix is not popular? Because the conventional teaching about external fixator is selling the same words and the same talk again and again and again. Remember, if you have a fracture, you have a bony injury and soft tissue injury. And actually, they are one thing. It's artificial division between the bony injury and the soft tissue injury. So again, are we talking about the same language when we talk about external fixation pediatric fractures? What do you mean by external fixation? Do you mean fixation in situ? Just to put the half pins above and half pins below and keep things as it is, like a cast? Do you talk about operative closed reduction techniques? Can you do closed reduction without any incision during the operation? Do you talk about post-operative closed reduction without anesthesia or analgesia? Do you know that we can reduce all the fractures after the operation while you are in your office without giving the patient anesthesia or analgesia, like you treat a deformity or something 1 millimeter per day? Do you talk about the corticotomy first technique? And I will show an example. Do you talk about 1-stage bone and soft tissue management? Do you talk about management of soft tissue defects without the need of a plastic surgeon? Which one? What do you mean by this expression? Again, classical teaching that the role of XFix is mainly temporary, span, scan, and fix, or span, scan, and plan. In open fractures, polytrauma. But people forget about the definitive treatment. Just a short talk about the temporary external fixation or fixation in situ. You just fix it in situ. Till you do internal fixation, you have to remember the methods of application and time on the fixator. And it has to be minor, simple, and easy procedure. And you have to avoid the intra-articular part, respect the anatomy, and bridging. All of this, I'm not going to talk about it. Let's go to the second part about the closed reduction techniques. Do you know that you can treat your fractures? You can do closed reduction of all your fractures. No open reduction. Open reduction is adding injury to the already injured part. So what we do, the real merit is that we can do closed reduction without any surgical incision during the operation or after the operation or both of them. This is an operative closed reduction. You have a fractured femur in this young girl and long spiral fracture. And this is an operative closed reduction. Used opposite olive wires, distraction, and this is the final. So this is operative closed reduction. And this is a neglected physial injury. Again, we use the closed reduction techniques to have anatomic reduction. And I will show you how. And this is the real example, post-operative reduction without anesthesia or analgesia. This patient was referred to me after 35 days of this comminuted floating knee injury. Comminuted floating knee injury. This is a war injury. He's 13 years old. We have an intra-articular, extra-articular, comminuted fragments infected. Open fracture infected. And this is immediately post-operative operation. Remember, we did anatomic reduction of the articular part using opposite olive wires. And look to the diaphysial part, total displacement. This is the post-operative X-ray 1 week after the operation. Total displacement. What we do with this total displacement of these fragments, we do gradual, this is coronal plane translation of this segment till we have anatomic reduction. You see here from this point to that point till we get compression by side. This is short oblique. If you do axial compression, you are going to have displacements. So after reduction, we do more so to get compression. Look to the lateral, we have total displacement, posterior displacement. Then we do sagittal translation 1 millimeter per day. You see here, this is under correction. This is over correction. Why we do over correction? Because of soft tissue interposition. Because this is after 35 days, you are expecting to have soft tissue interposition, and people say that if you have soft tissue interposition, you have to do an open reduction. Again, this is a non-evidence-based fact. This is not true. So we do over distraction to get rid of the soft tissue. This is magnified picture. This is anterior translation, where it was posterior, now it's anterior. And then we treat the patient as a deformity. We treat the fracture, the deformity, they draw the mechanical axis rear, and this is the cora. And we put distractor and hinges. And you see, you can have anatomical reduction. I'm not speaking about accepted reduction. I'm talking about anatomical reduction. Then we do long film. And if you still have some shortening, you can do distraction and use the fracture as a corticotomy, a closed corticotomy. This is the best corticotomy, closed corticotomy. See here, anatomic reduction and anatomic reduction. Again, corticotomy first technique, which we published 3 years ago. This is the case of fracture femur, which had been treated grade 1 open fracture and was treated by Nancy nails or elastic nailing. It's cut with the infection. And as the advice, severe infection, they removed and to put unilateral fixate. And we received the patient after 2 months with this severe infection, and we removed the fixator. And we did the corticotomy first technique. We drapped the infected part and we isolated. Then we put the frame in the proximal healthy part and we do corticotomy first. This is corticotomy first technique. Then we close it. Then we isolate the proximal healthy part and we go to the diseased part. We do resection and compression of the diseased part. And you see the healing of the infection because the corticotomy raises the blood supply to the liver. See, and continuation of the distraction. And just before removal, you see this is the area of lengthening. Again, are you going to do one-stage treatment, bone and soft tissue management in infected fracture? This is infected plate after 4 months, and they did many debridements. And the golden rule of the evidence-based medicine, if you have a stable fracture, you do debridement and debridement. Again, it's non-evidence-based medicine. There is no evidence at all. So we removed everything, and this is the soft tissue. We did minimal resection, not radical resection. We don't do radical resection, and we published that before 2 years ago. We removed only the anterior cortex. We left the posterior one, then partial corticotomy, rotational flap by the plastic surgeon. It's all one stage. And you see, we did corticotomy, partial corticotomy, and partial transport, magnified picture, partial transport. And you see here. The last case is management of soft tissue defects. Sometimes you don't have an osteoplastic solution. Like this case, you see that's the necrosis after open fracture. See here. And we showed the picture to the plastic surgeon, and he said, I got nothing to do with this patient. I have no solution. He has to do an amputation. And you see we have epiphyseal injury, comminuted injury of the whole tibia, fibula. And we did the corticotomy first technique. We isolated this part and we did the corticotomy first. Then we did the debridement. You see the gap. It's about 17 centimeter gap. There are no soft tissues. So here. Then we did compression of the debridement. This is the corticotomy first, compression. And this is the compression. Again, we did some translation. We did some displacement because there is an uncovered piece of bone. So we did translation, covered area. This is the corticotomy and translation. And you see the element, translation of the distal segment. And you see the picture. You see the gap for about 17 centimeters. You see the soft tissues without any osteoplastic procedures. Raising the blood supply can be enough to solve this problem. See before and after, and this is after the removal. In conclusion, external fixation has a definite role in treatment of pediatric fractures. Can be used as a in situ fixation, operative close reduction, post-operative close reduction without anesthesia or analgesia, corticotomy first technique, one-stage bone and soft tissue management of soft tissue defects. The real merit of external fixation or a circular fixator as a definitive treatment is close treatment of fractures, whether operative, post-operative, during follow-up, or without anesthesia. In conclusion, perhaps we don't talk the same language when we talk about external fixation in pediatric fractures. Thank you.
Thank you very much, Professor Gamal. Now we return back rapidly for a few questions to our guest speakers, starting with Professor Federico. Do you remember the question about the exact time or the maximum time you will interfere for a child with ankle injury, like Mcfarland fracture? What is the maximum time? You will, after that, you will stop, or you will prevent intervention for the boy or for the patient?
If I understand well the question, this is an emergency. Of course, if there is an associated dislocation, you have to reduce the dislocation in the emergency department.
Sorry. Okay, we understand. But if the child is missed or improperly treated, what is the maximum time you advise to do intervention? After which time? Maximum 1 week, 10 days, or less or more?
Usually we don't have this kind of situation because most of the patients are treated within the first 24 hours from trauma. However, if we have to, these are injuries that started to heal quite fast. In any case, if you detect this, if you miss this kind of lesion and you detect the patient within 1 or 2 weeks from the lesion, you can still try to reduce the fracture, but you will need to reduce by open means.
Yes.
However, if the lesion is detected, let's say 1 month, 2 months, 3 months, whatever, once there is already a fusion, the situation is different. The situation is different. You can try to correct the gap at the level of the joint, but you may not be able to avoid a secondary deformity in any case.
Okay, thank you. Another last question for you, Federico. What is the type of screws you advise to use during fixation of the tibial eminence fracture?
We used partially threaded screw, but the size of the screws depends on the size of the proximal tibia and it depends on which technique you are treating the tibial eminence, because you can use some sort of screws if you do it arthroscopically, and some other screw if you do open. It depends on the technique you are using. I do this fracture by open means.
Okay, you prefer to do biodegradable screws for such injury? Because if you put stainless screws or whatever, you should remove it after some time.
Yes, but I show the picture with some screws, and these were done by a colleague with arthroscopic technique. In my hand, I reduced these fractures by open technique, and I used a resorbable wires that I put at the level of the broken fragment, and I pull it down and I fix with the screw at the level of the tibial metaphysis to tract the tibial eminence down and to put the ligament in tension.
Okay, thank you. Professor Osama, I have only one question for you, sir, about the level of the wedging of the cast. You present your slides that you advise to do the wedge of the cast to correct varus or valgus at the level or higher.
Yeah, not more than 15 degrees.
Yes. Which is better, as a level or higher or below, according to the level of the fracture of the long bone?
As has been written in recent literatures, the higher level is much better. But really, for my experience, I tried very long time, since we started to treat fractures from 14 years, we treat by doing wedge as concavity of the angle at the level of the fracture. This is what had been trained for. Recently, there is new technique which should be done, or prefer to be done at higher level, but actually I didn't have experience in it. Okay, sir. Thank you. Professor Hassan, question for you. What is the line of treatment you should do for the child who is presenting with Salter-Harris type 1 fracture, fracture neck of femur, or Salter-Harris type 1 head of the femur injury?
Okay, it's Delbert type 1. First, it depends. It's type 1A, where the head is still in the acetabulum, or 1B, where the head is out of the acetabulum. For both of them, first we should, this injury is very common in below the age of 3. We should think about child abuse to take care for this. Next, we should go on for only one trial of closed reduction. Most probably it fails, and we should go to anterior approach and do the open reduction and internal fixation with K wires in the very young child, or smooth pins in older children. We're bypassing here the physis, and it carries the risk, of course, of physeal growth arrest, but this is the only way to fix it. Okay. The most important thing is to do the drainage of the hematoma, and this has very great effect in reducing the incidence of AVN.
Vascular necrosis. Yes, great. Okay. Thank you very much, Hassan. Last question for all the panels, and I think starting with Professor Gamal, what is the line of treatment, or what is your idea, or what is your plan for treatment of infected non-union of the fractured neck femur in pediatrics? Challenging.
You know, I have one solution. You know.
Yes, I know. So I asked you first, and then I want to hear our panelists about what is idea, what is the best plan for treatment of infected neck femur.
You know, most of the people, or usually the people, when they refer the patients to me because they got no other option. What does it mean? You have infected fractured neck femur coming after a couple of years. So there is no way to do reduction or something like this. You have to do pelvic support osteotomy or something. So that's it. So most of the cases referred to me are like this. in few cases that I do, fixation by external fixation. That means, just alignment and putting external fixation. Sometimes we put iliac fixation also to increase the stability. But
This
I
is
don't have
according to
much
the
experience.
Professor Gamali, you advise to do pelvic support osteotomy of such patient after age
The neglected cases.
neglected only at any time, at any age.
Yes, they come after, as neglected cases in our area is different from the neglected cases in the States.
Yes.
Neglected cases in the States coming after 5 days or something, but here neglected cases coming after 5 years.
Yes.
So and this is the real point when talking about two different languages, because sometimes we don't talk about the same patients, we talk about two totally different patients.
Not X-fix only, like Federico said, because we have not seen missed cases of distal tibial.
Yeah, exactly. So I'm talking, but I don't have experience of talking about fresh cases treated with valgus plate or something like this and had infection. I don't have experience.
Okay, I can shift to Professor Pierre or Patricia or Professor Vergal. Yes?
The head is viable.
Yes.
I think we should give him an opportunity doing a subtrochanteric valgus osteotomy, changing just the angle of the fracture, and even fixation with such a condition, even in the presence of infection, having union and then removing the fixation is giving a good opportunity for the child. Yeah. Because to sacrifice a viable head is something very great.
Yes. But if the head is not viable, Hassan, do you prefer to do something or leave him?
It's pelvic support osteotomy.
Yes, leave in peace. Pierre, you have any option?
No other option, but the question could be what is the indication of, for example, free vascular graft or something like that, because actually I have a case with infected non-union of femoral neck, and I put X-fix from the iliac crest to the femoral shaft in order to have a good stabilization and to remove all the necrotic soft tissue and debridements, and to perform swab for antibiotics. And actually, I have good stabilization and the gap about 3 or 4 centimeters. And I don't know what to do.
Professor Gamal has the solution. He's laughing. He's laughing. Professor Vergal, you have any opinion, or Professor Patricia, for your? You are muted, Professor Vergal.
Muted.
Yeah. Sorry, because we are too long story, too long time. We cannot hear you, Professor.
We cannot hear you.
Yeah.
Yes, try again. No. Is there a problem?
Can you hear me now?
Yes, now.
Yeah, good. Sorry. Sorry about that. I think Gamal summed it up. You know, we don't see that sort of case, and the one I just use standard principles of this, and I think unless you sterilize it, whatever you subsequently do is going to fail. And so it's to sterilize and stabilize. And for a femoral neck fracture, it would be very difficult. But I agree with Pierre, iliac crest to shaft to stabilize it. But then it depends on how much bone you have to remove and what you've got left to reconstruct. The problem with the femoral neck fractures that have become infected, once you've excised it, you sometimes don't have very much left to deal with. So that prompts people to do less than enough sterilization. And so they just refix something that's infected, and then they don't make any progress. So, I mean, I think it's a really, really difficult clinical problem, but I will just crest to shaft, remove what's dead. And then I think, as Pierre said, I don't know what to do next.
The same answer.
But at least it gives you a chance. If you can sterilize it and you've got proximal and distal bone that's alive, then it becomes a completely different problem.
Yeah.
If you can't get there, then it's eventually going to become something that you'll need to do either an excision and pelvic support or the girdle still or something like that. But until you can sterilize it, all bets are off for me.
Okay. Any of our professor guest speakers, anyone has any opinion or advice? Okay.
No, I don't have any experience.
Yes, please. Yeah, yes.
No, I don't have any experience on this type of case.
Okay. Finally, I am very happy to be with you tonight. And again, thank you very much for Professor Gamal and Professor Osama for inviting me to be moderator of this webinar. Thank you very, very much for your time. We have a long night, but again, thank you, Professor Gamal, and thank you, my dear professor, all of you.
Thank you, my friends. Thank you. Thanks, Patricia.
Thank you very much.
Thank you.
Thanks, Luigi. Thank you.
Thank you, Gamal.
Yeah.
Thanks very much, Gamal.
Thank you.
Thank
so
you
much.
very much. Thank you for having me.
Sorry for being late. Yeah,
Yes.
No problem.
Okay.
Not a problem.
see you all.
Yes.
في النهاية طبعا هنسمع محاضرة للدكتور مصطفى محمود شركة ساندوز. I would like to thank Sandoz company for their contribution. Thanks, Mustafa. Thank you, everybody.
Thank you. Be safe,
you.
everybody.
Bye.
See you soon. Bye-bye.
باي.
Bye-bye.
اتفضل يا دكتور مصطفى.
اوكي، مساء الخير. انا طبعا مصطفى محمود، براند مانجر ساندوز. حابب اشكر طبعا الدكتور جمال ودير بروفيسورز واول اتنديز طبعا فور ذيس اوبورتيونيتي. وطبعا موست ويلكم يا دكتور، احنا اكيد مع بعض بارتنرز مع الجمعيه، وانا بشكر الجمعيه ان هي ادتني الفرصه دي النهارده ابقى موجود مع حضراتكم عشان خاطر طبعا مش بكونسيوم سو ماتش تايم يعني. انا هجيب هيت بسرعه كده على الدايكلاك از دايكلوفيناك صوديوم فروم ساندوز. واتفقنا قبل كده ان في حاجه مميزه جدا في الدايكلاك في الايفنت في التابلت في البرودكشن بتاعه، ان هو بالاي دي تكنيك عباره عن 2 تابس موجودين ببعض، حاجه فيها immediate ريليز اللي هي 25 مللي جرام
دكتور
و125.
اكسكيوز مي، ممكن لو تكمل بالانجلش لان في ناس لسه معانا منهم فهو حابب انترستد يسمع معانا.
اوكي
تدريكه، فاذا كان يعني بنفس اللانجوج.
شور.
شكرا.
Okay, again, I'm Mustafa Mahmoud, brand manager from marketing team in Sandoz, Egypt. So delightful to be here with you today, and I'm introducing a quick presentation about Diclac, which is a diclofenac sodium from Sandoz. Diclac is the trade name of diclofenac sodium of Sandoz here in Egypt. So we have like 4 SKUs or forms from Diclac: ampoule, 75 tablets, and 130 tablets, and in topical form. What's so special about Diclac as a diclofenac? First of all, it's the technology of the production of the tablet. It's by tap. The tap in the real life, as this picture, it's 2 taps on each other. First one is immediate release layer with 25 milligram, and the white layer is the sodium, diclofenac sodium slow release. So once daily, diclofenac 150 or Diclac 150 cover 24 hours. But it's so special because we have the immediate release layer, which gives fast onset of action, in addition to the slow release layer, which continues for 24 hours. The same for 75 milligram, but here you can see that the concentration is the half, 12.5 and 62.5 for the 2 layers. So it's taken twice daily to cover 12 hours. Of course, the recommended dose for diclofenac is 150, so you can take 150 once daily or Diclac 75 twice daily. Okay, first I need here to highlight about what's so special if I take diclofenac 50 milligrams 3 times daily versus Diclac 75 with ID technique. First of all, I will have the privilege of being fast onset of action, so you can hear the reduction of pain in the 24 hours is much more significant than the Diclac 50 milligram, which is now 3 times daily. I think it's not more compliant for patients. So even a patient receives 3 times daily from diclofenac traditional 3 times daily, it will not give the same fast onset action like the ID technique or the diclofenac with the production of ID technique. Here I'm talking too about the ampoule. We have 75 milligram ampoule, course 75 post-operative. So to reduce the pain and reduce the need for opioid doses. So it's way more significant if patient received diclofenac post-operative to reduce the need of opioids for the first 48 hours. Finally, I have the 5% gel, which is the highest concentration in Egypt from other diclofenacs. Hydrogel, high penetration, and high, as I said, 5% is the most or the highest dose, so it might be more effective. Finally, thank you for your time, and if you need to ask me any question about this product, so most welcome.
Thank you, Dr. Mustafa, for your presentation.
Thank you very much.
I have no question from the audience or the penalties. If Professor Federico have any question about the drug, you are welcome. Professor Federico, if you have any question. Professor Hassan, I have no question in my challenge. Thank you, Mustafa.
Thank you, Professor. Thank you, Professor Gamal.
He finished his presentation, Mustafa, Professor Gamal.
Good night. Thank you.
Good night.
Good night, Federico. See you.
See you. Bye.